Delivering critical medical care across thousands of square miles of rural terrain requires massive logistical coordination. In many regions, a patient in a village experiencing a cardiac event is hours away from the nearest equipped specialist, relying on a deeply fractured transit path to reach a distant urban center. This map shows the demographic reality of Andhra Pradesh. We are looking at a population of over 8.5 crore people, where roughly 66% reside in the widespread rural zones highlighted across the state. This vast population relies on a severe infrastructure bottleneck. The entire state is served by only 13 district hospitals. Outside major cities, regional reports indicate critical shortfalls in high-end medical equipment, specifically in radiology, oncology, and intensive care capacity. The state cannot simply build its way out of this deficit using traditional public funds. The 2026-2027 Andhra Pradesh capital health budget sits at roughly 3,061 crore rupees. That is only 5.8% of the state budget, falling significantly short of the 8% target set by the National Health Policy. Compounding the lack of physical beds is an operational failure known as the silo effect. Existing community health centers operate completely cut off from urban tertiary hospitals. When rural patients finally reach a specialist, their medical history doesn't travel with them. This forces duplicate testing, extends wait times, and drastically increases the cost of diagnosis. Injecting minor capital into this fragmented system yields diminishing returns. Bridging the gap between the rural population and urban critical care requires an entirely new operational architecture. The Union Health Ministry has urged the state to adopt a collaborative model to build out its diagnostics and imaging networks. Project Ophiuchus is designed specifically to execute that mandate. This diagram illustrates the core structural thesis of Ophiuchus. Instead of a standalone mega-hospital, it is an integrated healthcare cluster. A central multi-specialty hospital acts as the hub, directly linked to a decentralized network of local diagnostic centers and tele-ICU nodes. The physical, concrete and steel, are secondary to how the system communicates. The true core of the cluster is a unified digital health platform. Every outpatient clinic visit, lab test, and prescription is instantly tracked, digitized, and shared across the entire network. This structure serves a dual mandate. First, it radically improves primary care access for local, underprivileged patients. Second, by centralizing top-tier specialists and equipment, it creates a highly appealing destination for lucrative international medical tourism. To construct this without draining state resources, Ophiuchus relies on a novel public-private provider partnership. The entire network is owned and operated by a special purpose vehicle, or SPV. Before a single foundation is poured, Ophiuchus engineers a system of aligned financial incentives and strict digital interoperability. That structural alignment is what guarantees the network's long-term financial viability. The governing entity executing this is tentatively named Ophiuchus Health Infra Private Limited. This SPV functions to distribute risk and reward precisely among the groups required to make the hospital function. Looking at the macro funding structure, we see how the capital expenditure is divided. Approximately 30 to 40% of the required capex is funded through traditional bank debt or bonds secured against the hospital's assets. The remaining 60 to 70% is covered by an innovative equity pool. The institutional stakes are split between the public and private sectors. The Andhra Pradesh government takes roughly a 20% equity share in exchange for providing the land and viability gap funding. Private investors and corporate social responsibility funds provide the heavy capital lifting, holding roughly 50% of the SPV. The most critical innovation in this cap table is the clinical equity. The founding doctors form a cooperative, holding a 15 to 20% equity stake in the central SPV itself. This solves the leading cause of failure for healthcare infrastructure projects: low utilization. Building an advanced operating theater is a massive liability if top-tier surgeons prefer to practice at competing facilities. By turning practicing physicians into part owners of the infrastructure, they are directly incentivized to bring their patients into the Ophiuchus network. The SPV guarantees a steady flow of patient volume to its high-tech facilities, naturally protecting the private investor's capital. With the macro ownership established, that financial alignment scales all the way down to the daily unit economics. Every single medical service provided within the network generates categorized revenue. Looking at this revenue split matrix, we see a dual incentive model. Income is divided dynamically based on the ratio of clinical skill required versus the cost of capital equipment used. For routine clinic visits, the model heavily rewards localized practice. Doctors retain 80% of their outpatient consultation fees. The SPV takes a 20% cut to cover facility and coordination costs. However, for capital-intensive tertiary care, the math flips. For ICU bed days and complex MRI scans, the facility absorbs heavy depreciation and maintenance costs. In these instances, the SPV retains between 50% and 80% of the generated revenue. The SPV also operates the central pharmacy and curates the medical tourism packages. These high-margin pipelines belong predominantly to the hospital network, generating 60% to 70% margins deployed to rapidly pay down the facility's construction debt. This tiered revenue matrix highly compensates doctors for their time and expertise, while ensuring the SPV captures the margins necessary from heavy machinery and premium services to remain solvent. Managing variable revenue splits across dozens of rural outposts and a 500-bed central tower is practically impossible using traditional, fragmented IT systems. It requires a unified technology backbone. To achieve this, the network strictly adheres to the Ayushman Bharat Digital Mission, or ABDM, standards. Every patient is assigned an ABHA-enabled ID, and all facilities communicate using standardized HL7 and FHIR data protocols. In practice, this creates a seamless workflow. When a patient arrives at a remote rural node, an AI-driven triage system manages their initial consultation. If the rural physician orders a scan, that order routes instantly to the central lab. The results populate directly back into the patient's electronic medical record, ready for a central specialist to review in real time. The financial impact of this workflow is measurable. Consolidating lab work, complex imaging, and pharmacy fulfillment into a shared infrastructure eliminates redundant testing and cuts per-patient costs by 20% to 30%. Interoperability provides the economic mechanics that make a decentralized hub-and-spoke model viable. Attempting to build and launch an 800-bed multi-specialty ecosystem all at once carries extreme financial risk. Ophiuchus avoids this through a strict 4-stage phased rollout executed between 2026 and 2030. Looking at this 10-year financial projection, we can track the aggressive scale from the initial capital injection to sustained profitability. In phases 1 and 2, the network starts lean. Approximately 150 crore is deployed to build out the rural diagnostics hubs, tele-ICUs, and minor surgery centers. Operating at an initial EBITDA loss, these early years establish the vital data network and generate initial patient volume. Phases 3 and 4 deliver the massive 350 crore capital injection required to construct the main hospital tower. By year 5, the network reaches break-even on operating expenses, pushing top-line revenues toward the 400 crore mark as complex surgeries scale up. This phased approach proves the efficiency of the digital platform and rural referral pathways first, mitigating early risk before fully funding the massive urban tertiary tower. There is one final tension to resolve. A highly profitable 400 crore medical network must still fulfill its mandate to serve the local, below-poverty line population of Andhra Pradesh. The solution is cross-subsidization. The SPV actively targets international medical tourists from the Middle East, Southeast Asia, and Africa. These patients pay for high-margin bundled packages, including surgery, visas, and recuperative wellness care. This influx of international capital is bound by strict service-level agreements. The SPV uses these high-tier profits to subsidize local care, covering the cost of reserving 20% of its beds for free or low-cost treatment under state welfare schemes like the NTR Trust. By Phase 4, the fully realized end state is an advanced health tech hub operating at 80% to 90% occupancy, complete with medical incubators, training wings, and wellness programs. Project Ophiuchus attempts a structural shift. By fusing doctor-aligned equity, ABDM data standards, and aggressive cross-subsidization, it establishes a model for converting regional healthcare deficits into sustainable, globally competitive infrastructure.